everyone. So I hope to speak to all these issues, and I actually packed a lot of material. As I was presenting, preparing for the presentation, I had so much fun. So I even included a video, and maybe it's also because I'm teaching a spring course, so I'm in my, wearing my professor's hat. I taught yesterday, we'll be teaching tomorrow. So in between, trying to do this. So I'll try to go through all of this. Now the vignette that I'll be presenting is actually informed by some research studies that I've done, but also there is an element of fiction there. So I invite all of you to engage in an interpretation with me. Then I'll be talking about actually one key consideration under which there will be several sub-considerations. And then if we have time, I'll be presenting some qualitative data, some excerpts from focus groups that I had the opportunity to conduct a few years back. And if we have time, there will be a small segment of a video, but if not, I'll be more than happy to share it with you, because I think it actually speaks to the sort of action part in terms of, so okay, we live in a risk society. We do know that maybe, I'm not fully agreeing to the fact that we tend to believe what we believe, and we will go with that. But as communication specialist, I always try to come up with solutions, or at least attempt at finding solutions. So communication strategies that we can use. So the video actually does speak to that. So in a nutshell, these are some of the, I guess, health risks, or environmental risks that we are faced with on a daily basis. So German sociologist Beck coined the term risk society. So we do live in a risk society, and although our scientific and medical knowledge about health and disease has increased, health professionals and communicators are still frustrated because individuals do not behave rationally. They ignore medical advice, and maybe I can say that I do, smoke, which I don't, consume unhealthy diets, practice unsafe sex, and become overly concerned about what are, from a risk assessment perspective, minor risks. We may worry about the Zika virus with family and friends as we continue to smoke, consume high-fat foods, or ignore our doctor's instructions. We are Homo sapiens, what to do, right? So risk communication actually emerged primarily from a scientific and technical perspective. In this context, the social and cultural dimensions of risk are judged to be marginal concern. So that is where I'm coming with my presentation. So there, we can say that there's a disconnect between the scientists and the experts, because they're the people who think mostly fact-based, and then you have the publics, right? We feel, we believe, and mostly our notions are value-based. Again, this is the notion that I'm coming with. So the vignette, I will be actually reading this out loud, and the highlighted text, if you could just pay attention. Later, maybe together we can interpret. Maybe what are some key considerations coming from this case. So imagine in your mind Fatima, a 55-year-old woman working at her sewing machine in her old Barhaven condo. She was born in Saudi Arabia and lived there 20 years before immigrating to Ottawa, Canada. Fatima stops the sewing machine as her son brings her letters in the mail. Muting Paula Abu Haider at Arabic program Chin Radio Ottawa 97.9 FM, Fatima opens the invitation letter from the Ontario Cervical Screening Program to book a PAP test. The letter begins, and I quote, "Dear Fatima Al-Siddiqa, we are writing to invite you to get screened for cervical cancer. This year, cervical cancer will be found in about 1,500 women in Canada, and at least one woman will die every day from this disease. The good news is that you can take steps to protect yourself from cervical cancer by having regular PAP tests." And I close that quotation. So Fatima loses interest right away and stops after reading this first paragraph of what happens to be a one-page letter containing a brief description of the warning signs of cervical cancer, what a Pap test is, and the associated benefits. A call to action to get in touch with the family doctor to schedule a test, contact details for further information, and a signature from the VP of Prevention Cancer Control, Cancer Care Ontario. Now what Fatima does, she crumples and throws the letter into a wastebasket, which was standing next to her sewing machine. And within quotation, I utter, I better finish hemming these last 3 pants before Mrs. Butterworth comes knocking on my door anytime now, mumbles Fatima. So that's the reality that she's living with. So I will leave you with that. And I'll go back to the idea of, try to juxtapose Fatima's situation with the average Canadians. And I don't know how we can define them. So Canadians are warned of potential health risks from infectious diseases and are urged to take personal precautions by being vaccinated, covering exposed body parts, hand washing, avoiding certain travel destinations, and so on. So the list of health threats is long and includes, to name only a few, West Nile virus, SARS, mad cow disease, and to this day we are faced with the Zika virus. So media headlines identifying threats can be confusing, anxiety-producing, and frightening even for those with excellent prose literacy, numeracy, and science literacy skills. There is an assumption that as readers of risk information, we have a number of literacy skills, from being able to read the information, which is prose literacy, to understand what the statistics and numbers mean, which is numeracy skill, to having a basic knowledge about what bacteria are, which is obviously science literacy. Unfortunately, gaps in these skills are all too common and affect comprehension and action by concerned citizens who need to respond to public health risk settings. Now, if you remember, I was talking about Fatima, who is an immigrant. Now, for the average Canadian, I think it's now a little higher than 60% of Canadians actually read below the required health literacy level. So that's a reality, and it includes non-immigrant population groups as well as it includes the indigenous population, then mostly elderly and women. So many of the features of communication between two people apply to risk communication to the public. These features include how the risk information is, which is encoding, how is it delivered, which is transmission, and how it is understood, which is decoding. Problems develop when the information processes break down. Even simple words between two people are perceived differently depending on your cultural background, the linguistic skills you're bringing into the table, the perceptions that we hold as individuals of obviously our assumptions, the shared history or individual history, and social dynamics. Because risk communication involves many people with diverse cultural and language backgrounds, the consequences of miscommunication and misunderstanding can be enormous, sometimes, life-threatening. So, we, listen to the story of Fatima. We sort of have an idea of the Canadian population in general. Let's take a look at the focus group findings from 2 of my studies. So in this study, what I did was I had the privilege to investigate, understand immigrant women who self-identified as Muslim, and they talked about their health beliefs. So based on their lived experience, they actually identified healthcare that would be appropriate, offensive, and recommended. So let's take a look at, and I'll try to read now. For verbatim purposes, the excerpts are actually not filtered, so you just have to bear with me. So in their opinion, appropriate care would be respecting the patient's opinion and not stereotyping the patients, because unfortunately, for many of the Muslim immigrant women, because of the way they present themselves, wearing hijab and whatnot, oftentimes they are being stereotyped. So this participant is mentioning that talking about the doctor who turned his shoulder, he was avoiding talking to me. I'm looking at myself, compared to you, I'm better, I'm modern, I don't look like someone who looks conservative, because obviously the doctor is not wearing hijab. So I had to start like telling him, so that he gets the impression that we can communicate. They don't take us seriously, they have a lot of stereotypes about us. So an offensive healthcare practice would be disrespecting patient's modesty. So in this case, the Muslim patient, the women, not treating patients with dignity. I had a laparoscopy. A female doctor was doing it. She needed an assistant. She knew that I did not want a man in the room. So the patient, the female Muslim patient, specifically said that she doesn't want a male physician's assistant. Everything was all female, but when I went back to her after 6 months, she gave me the copy of the surgery. There was the name of a male doctor there. He had come in during surgery. So obviously that was a breach of trust. So recommended practice would be having cross-cultural education, understanding patients' religious beliefs, which is very much related to how an individual from a different cultural background having certain spiritual beliefs would perceive health risk. The problem here is understanding our religion from all caregivers. This is what we need. The community has to do it. Once or twice a year, do a presentation about our religion to all healthcare givers in Canada. This will help a lot. Now, in the interest of time, I'm going to skip this and talk about some key considerations. So actually, just basic, one concept that I'll present to you is cultural sensitivity. And this is how the scholars have defined it. The extent to which ethnic, cultural characteristics, experiences, norms, values, behavioral patterns, and beliefs of target population, as well as relevant historical, environmental, and social factors are incorporated into the design, delivery, and evaluation of targeted health promotion programs. So there are 3 reasons why we should be considering this in the context of Canada. Obviously, Canada is a multicultural society. You know, nowadays we have the influx of immigration and refugee. So if we take smoking as a health risk, studies actually have found, and they don't necessarily focus on culturally background, people with different cultural background, that there are racial and ethnic differences noted in smoking prevalence, cigarette brand preference, age of smoking initiation, exposure to environmental smoke, and number of cigarettes smoked per day. So as you can see, if you boil it down at really micro level. Also important would be different norms for communication channels. So people, depending on the cultural background they have, their religious beliefs they have, the socioeconomic status they have, the educational background they have, the gender, the sexual orientation, they would actually prefer maybe peer-to-peer communication, counseling, over being exposed to a mass-mediated campaign. Some of them might be more prone to discussing issues, maybe health risk-related issues on social media. So it really depends on the individual or a group of people. So this actually brings us to the idea of designing for culturally sensitive public health risk interventions or programs. And there are 2 approaches that scholars talk about. One is the cultural targeting and the cultural tailoring. So what cultural targeting does is actually looks at the group level. It takes into account the group level data to customize health messages for a specific audience group or segment. But you go into a higher level customization and audience segmentation, where you actually look at the individual level of data to achieve that goal. So before, I think, do I have time to show this second?
How long is the video?
It's going to be 2 minutes,
Let's
something like that.
wrap it up with that, yeah.
Oh, all right, okay. So before I go into the video, the remarks that I want to make is that as a field of study, risk communication is rooted in the foundations of democracy. From the very beginning, we should be engaging the public, the target audience, not only in terms of when we're thinking about risk management, but risk assessment, risk analysis. So we should be actually doing needs analysis, and also engaging them in developing risk communication strategies so that we can ensure better risk management.